everybody, and welcome to Anatomy Geeks this Tuesday. Usually you see Dr. Osar standing here and doing the introductions, but today Dr. Osar is actually out of town, so we have a special guest, Miss Jenice Mattek. Woo! Good to see you.
Good to see you, Jill.
And we're here today because we're going to talk about the Rectus Femoris, which is one of the quad muscles, the quadricep muscles. And it's the one that has a name that doesn't match the other three. So just as a quick review, your four quad muscles are your rectus femoris, which we're going to talk about. You have vastus lateralis, you have vastus medialis, and then you have vastus intermedius. And rectus femoris not only has a different name, but it also has a different function, and it also has two completely different, well, I should say one different attachment than the other quad muscles. And it is the only one of the quadricep muscles that crosses both the hip joint and the knee joint. So all the rest, the other three quad muscles, they only cross and act at the knee joint. And the rect fem does both. It acts at the knee joint and it also acts at the hip joint. So I just want to kind of give a quick little review, and we're going to do a close-up shot right now of the rectus femoris. And it is this muscle that is going to be right here, that comes down the front of the thigh. It has an origin up here of the anterior inferior iliac spine, and then it comes down here to the tibial tuberosity. And if I may, I'm going to show the fiber direction on Ms. Jenice here. So when I'm finding rectus femoris, I am looking for my client's ASIS, which is that very prominent bony landmark on the front of the hip. And then I just move about an inch diagonal and medial to get to the general location of where the origin for rect fem is. So I'm going to find her ASIS, move just a little bit medial, and then it's going to come down, and I'm going to find her tibial tuberosity, which is just an inch below the patella, and boom, there's going to be that fiber direction, for rectus femoris. So what it does at the hip joint is, when it contracts concentrically, is it's going to flex the hip joint, and it is going to extend the knee joint. So flexes the hip and then extends the knee joint.
So one of the things that people tell us is, I always feel like I have tight hip flexors.
Yep.
And we just learned one of our hip flexors is the rect fem. So they like to do a hip stretch. And so we thought about that today. We thought about the hip stretch. We did a lot of hip stretching today. And one of the things we learned was, when Jill tried to do an anterior hip stretch, I want you to see what happens. So she can't really get into the position without modifying her entire trunk to get into that position. So we said, okay, well, let's modify that. And we had Jill try to do the same thing in sideline. We had her do it in multiple different ways. And as part of the integrated movement system, you can relax that, Jill. As part of the integrated movement system, we like to use assessments to see if what we're having our clients do is having the effect that we're intending. And so when we're thinking about stretching, we're thinking about creating length in a muscle. And so I do a couple of assessments with Jill. And one that we can do to test the length of somebody's hip flexors is the Thomas test. And that's when you had somebody sit on the edge of a treatment table, have them bring one leg up to their chest and roll back, and you're actually assessing the leg that comes out straight. And what we noticed with Jill's hip flexors is that she actually had pretty good length. There was no shortness. What we did notice, though, is she had some tight abductors pulling her out. And so when we actually palpated her rect fem, there wasn't even tenderness in her rect fem. However, there was quite a bit of tenderness in her vastus lateralis, her outside quad. So I was able to use an assessment to say, well, Jill, I don't really think you need to be lengthening your rect fem because it already has pretty good length. But I went further to say, well, Jill, when you get into that, I will call it a convoluted position of getting way back in extension to stretch this out, let's see what happens to your strength or your ability to stabilize once we do that. So we did a couple of muscle tests. After she did that, and Jill's eyes got about this big, and I said, Jill, are you holding the test? And she
actually said, I think you're pushing too hard. I was like, I'm not this weak.
And she had zero ability to hold a hip test as well as her QL test. She was unable to hold that as well. And so I had to help put Jill essentially back together. And so we actually did some breathing as well. And that brought her back together, and her hip test was strong again. However, I wanted to test it again to make sure. And we had her do the exact same, one simple sideline hip stretch, and the exact same thing happened again. And we did our Thomas test again. It did not change her abduction. That was still very tight. And we actually gave her too much length through the front of her hip, where her leg was almost touching the ground, which is too much. So we actually learned quite a bit. And so how would you have someone stretch their hip flexor? Well, first we learned you have to test to see if that's actually what they need. Because if your client is in a posterior pelvic tilt, Jill, if you want to show us what that would look like, when Jill was talking about the difference, the length between the AIIS and the tibial tuberosity, we could see that when she goes into a posterior pelvic tilt, it actually puts that rec fem on stretch. And so maybe the tightness Jill may feel is more of a lengthened tightness, like tight like this rubber band is, versus a short and tight feeling. So something to think about is when your clients say they have these tight hip flexors, do an assessment to see if what they're feeling is the same as what's actually happening. And that will help you determine if a stretch is what they need, or do they need to be doing something else to make that feel better and working optimally for them. So that is our bit on the rec fem. So we hope you enjoyed this. This is some of what we go over in our courses that we offer. We have our Integrated Corrective Exercise Instructor course, which, Jill, what would you say about that course? You just recently took it. What were your big takeaways from that course?
That what you may have learned in either massage therapy school, in what you've learned as a personal trainer, that some of those things not necessarily aren't true, but you need to be more aware of different perspectives to look at a client's issues coming in to see you.
So we go a little bit deeper into that course, our 2.5-day course, but you can imagine when you think about having to understand everything that has to happen with your clients, and you have those really challenging clients like some of our older clients are, you also want to delve a little bit deeper. And so Jill is now currently, while she's working with Dr. Oster, going through her Integrative Movement Specialist certification, which delves much deeper. It's much more complex in the material that we cover, but Dr. Osar is known for making complex material easy to understand. So those are our two big courses that we offer, and then in the beginning of March, we're actually doing a course here in Chicago, right here in this space, where we're going to be talking about women's fitness, working with your clients post-surgery as a half-day course, and then reframing how we look at the core and core training to really promote spine and joint health. So space is limited for all of our courses, but we would love to see you at one. If you can't make it to a course anytime soon, be sure to check out our website at www.iihfe.com. Thanks so much, and Dr. Osar and Jill will see you next Tuesday for 2 Anatomy Geeks.